Next, we have Dr. Aday talking about SCAD and considerations in the clinic.
Great. Thank you, Esther. So I'm going to talk mostly about medications and some lifestyle changes, but I just want to first acknowledge, that transition from being in the hospital to leaving the hospital after SCAD, that's a really scary and trying time for a lot of people. And when you're in the hospital, you're surrounded by doctors, you can get a million EKGs, whatever testing you want. And then once you leave, you're just waiting for that appointment. And who knows how long that appointment's going to take? Who knows if that doctor is familiar with SCAD or FMD? And so I think when you do get in the office, it's okay to acknowledge that, to voice some of that anxiety. Have a good cry if you need to. Maybe you need a couple office visits to really process everything. So that's really important. I don't think you should feel guilty or unable to voice that. So I just want to start with that. All right, we're going to start with our Minty question. So which of these following treatments is recommended for long-term SCAD treatment? Dr. Wells talked about this a little bit. All right. So most people say beta blockers, and I think that's probably the best answer here. And we'll dive into this. And I think it's important, this notion of what is a blood thinner, we'll talk about that. And that may be some of the source of confusion here. So when I think about what medications I'm using for SCAD, you just want to think about what is SCAD compared to a typical heart attack. And we've heard this a few times today. So again, with SCAD, we're talking about a tear in the lining of the artery or bleeding within that vessel wall itself. You're getting compression of that blood vessel, and that's what's starving the heart muscle of oxygen and nutrients. You may or may not have a blood clot in there as well, but it's really that starving of oxygen and nutrients to the tissue itself. That's very different from a typical heart attack, right? That's where we're getting atherosclerotic plaque building up over time. That plaque cracks open, you get a blood clot develops, and that blood clot is what blocks the blood flow there, okay? The vast majority of our medications and all of our clinical trials are for people with standard heart attacks, right? So we're extrapolating pretty much everything from that, certainly in terms of our large clinical trials for how we treat SCAD. So you just want to understand that knowledge gap and that research gap in terms of what we're recommending in the clinic. So when I'm in the clinic and we're talking about medications for SCAD, these are sort of the four main reasons I'm thinking about using medications at all. One, we want to deal with chronic chest pain if that's part of what people are experiencing. We want to make sure SCAD doesn't happen again. We want to make sure, use this as an opportunity to address blood pressure and cholesterol. And then there's some specific populations. If you've had a stent, bypass surgery, or if you have heart failure as a result, there's a little bit of different things we want to talk about. So chest pain, we heard about this from Dr. Wells in the hospital. Not everyone, but many patients with SCAD will have some chronic chest pain. This may be, in the first few days or weeks after the event. This could be a chronic, lasting many months or even years. But we want to be able to help patients through this. So we use things like beta blockers to slow the heart rate down, reduce the strain on the heart. We talked about nitroglycerin. There are long-acting forms of this that may be part of your medical regimen. Calcium channel blockers or some other less common medications, something called ranolazine. The key is just that we have a lot of medications to help with this, and you shouldn't be afraid to bring this up if this is something you're experiencing. Also, I think cardiac rehab is really important for anyone after a heart attack. That's part of what we recommend for people with SCAD. Again, you're undergoing exercise, you're closely monitored. You're going to have some pain, some twinges, something's going to feel not right. You want to be there with a nurse and a physician who can say, you're okay, keep going, keep pushing yourself, let's work through this. Or, well, let's monitor you, let's slow things down, let's back off a little bit. You need that guidance after this has first happened. Other things we talk about. So we mentioned, and this is a little bit of nomenclature, blood thinners versus antiplatelet medications, okay? And so for doctors, these are a little bit different. I think that's often lost on patients. We don't do a good job of communicating that. So when we say blood thinners, we're thinking of things like Coumadin or heparin, which is given through the IV. Those are typically things you're using in the hospital when you're first working someone up for SCAD. that is uncommonly going to be part of your medication once you're in clinic. And so sometimes you may come to me, and if that's still part of your medication regimen, we'll talk about trying to stop that or try to figure out why you may still be on that if there's a different reason. Now, antiplatelet medications, those are things like aspirin, Plavix, or clopidogrel. Again, I'd say most of us typically use aspirin as part of the long-term management after SCAD. Again, we don't have a 10,000 person randomized controlled trial recommending that, but I think that's pretty much our standard practice. Now, if this was a standard heart attack, we would be using aspirin plus a second medication in this class. Okay, and we have many clinical trials to give us evidence to do that. We don't have that for SCAD, and I would say you're going to get different answers, but probably most of us use one of those second medications for 1, 2, 3 months, maybe no time at all. It kind of depends. But again, we don't have a lot of information to guide us in there, but we certainly don't have those big 10 or 20,000 person clinical trials to give us information. We talked about beta blockers. I think these are very important, very helpful for patients, many different types, and we have long-acting forms. Sometimes you leave the hospital and you're taking a single medication 3 or 4 times a day. We can clean that up when you come into clinic. And so bring that up if you're worried about pill burden or just trying to figure out what you're taking and why you're taking it. Don't be afraid to bring that up with your doctor when you're in the clinic. So I think blood pressure is important. I always tell patients after something like SCAD or any other vascular event, this is just a good time for a checkup. What else is going on? How can we optimize your heart and blood vessel health and make sure we're not adding anything else to the mix? So even if your blood pressure was not a primary trigger for SCAD, we'll make sure it's under control. So targeting less than 130/80. We have a lot of medications to help us get there. Diet, exercise, weight loss can also help with that if that's relevant. So we'll be talking about that. Again, we don't think that high cholesterol or atherosclerosis are really driving SCAD, but this is a great time to say, let's check your cholesterol. I'll usually check something called lipoprotein(a), which is a different type of bad cholesterol that's determined by your genetics. This is an ideal time to say, what else is going on? How can we optimize your overall cardiovascular health? And talk about whether you need medications for that. Other things here on the right, we talked about getting to an optimal weight, exercise, a heart healthy diet. Probably the most evidence would support a Mediterranean diet. If you smoke, we got to get you off cigarettes, right? That's a huge factor, and this is a great time to talk about that. So all of these are part of those initial visits when you're in the clinic. I talked about this morning, arteriopathy. So why did you have SCAD? Let's run through the list of possibilities. Think about FMD. Think about other potential etiologies. That head to pelvis imaging, that's something I'm talking about in that first visit when I'm seeing you in clinic. So again, we're looking for those classic findings of FMD, like we see here on the left, that those bead on a string. Other things you might find, a complete loop in an artery, a twisty artery that's sort of an S shape. All these things may come up on that imaging. And I think you find stuff no matter what age patients come in. These are some data from Dr. Kim through the Vanderbilt clinic, looking at patients who came in, they had SCAD, there was different age groups, young patients less than 40, 40 to 60, and those older patients who were 60 and above. They all had head to pelvis imaging. And you see here on the bottom, a lot of them had FMD, about half had FMD, around 15% had an aneurysm. So there's no cutoff to where you would not do this additional imaging. You want to know what's there and help patients understand if they have one of these arteriopathies. Now, sometimes, especially before patients come to see me, there may be some concern about having the imaging done, concerns about radiation, the dye that you may get with a CT angiogram. It can be challenging going from multiple scans. I think this can be simplified a little bit. Again, these are some data from Dr. Kim through the Vanderbilt clinic, where she helped develop a single protocol scan. So one-time scan, head to pelvis imaging, you're in the tube one time, you're not having to come back for multiple visits. You can reduce the radiation, reduce the contrast, and it works just as well. Other places have this as well. And so I think this is something that can be scaled up at other hospitals. So again, if those are some concerns, I think we can address that and reassure patients that this should still be part of your evaluation, and we can help work through concerns about radiation and contrast. So finally, some of the special circumstances. What if you had a stent for your SCAD? Well, I think that's a little bit of a different situation, even though you didn't have that stent put in because of atherosclerosis. we want to make sure that stent stays open, okay? And so we do need some extra medications to do that. Besides just aspirin, you're going to be on a second one of those antiplatelet medications. There's several different ones. Depends on what the person who put it in wants you on, insurance, things like that. And how long you're on that second medication depends. There's some technical considerations. It may depend on the specific brand or type of stent. Somewhere in the 6 to 12-month range is pretty typical again. And your medical team can help you understand that. But just so you understand, if you have a stent put in, it's a whole different set of recommendations for that class of medication. Okay. Now, what if you had a bypass surgery, a coronary bypass? Well, again, we're going to put you on an aspirin and a beta blocker. We want to do everything possible to keep those bypass grafts open. Again, even though it wasn't due to atherosclerosis, we need to baby those bypass grafts. And then some patients will develop heart failure as a result of the SCAD. This is a minority, certainly, but if you have damage to the heart muscle where the heart is not pumping as well, again, very different situation. We want to be very aggressive about getting you on a full set of medications to boost the heart pumping capacity. Again, we have many, many clinical trials in this space, not for SCAD specifically, but really for anybody with heart muscle weakness. And this should be part of your regimen. Start it as early as possible and be very aggressive with this. So just a few take-home points. Again, SCAD is very different than a typical heart attack, so our treatment's a little bit different. I really think that aspirin and beta blockers are the cornerstone for our long-term treatment. Again, we typically don't need long-term treatment with a second antiplatelet agent, something like Plavix, unless you've had a stent put in. Everyone needs their blood pressure controlled. Not everyone needs cholesterol medication, but I think it's a good idea to have your cholesterol checked. And then all patients need that arteriopathy evaluation that we discussed this morning. Thank you.